I think everybody has heard the data that were presented at ASH, the data of ZUMA-7, comparing the use of axi-cell immediately after relapse versus salvage plus transplant, the data of Belinda, which compares salvage followed by transplant versus bridging T-cell followed T-cell, and the data of Transform, who evaluated in this setting Liso-cel with an optional bridging. I think there have been an excellent review paper in Blood by Jason Westin and Laurie Sen just a few days ago, reporting the summary of this data. And I think there are a couple of insights. As we know, the result of these patients that were selected based on either being refractory, and in the 3 trial, I think 60 to 70% of the patients were indeed refractory, and or having a relapse within 12 months after completing therapy, was better in 2 trials compared to ASCT, and Belinda didn't show a difference. So the question is, do you feel based on these results that you should change your strategy or strategies that was established 30 years ago? I mean, obviously, it depends on the approval of this product, which may differ country by country. Are there some subcategories of patients that you feel are not necessarily part of this trial or not well explored in this trial that may still benefit from classical management? These are probably the question, and I think we can go that on a round table. I don't know who wants to start.
I'll kick off. I'll give it a go. So, look, I think for most of us, when we look at using CAR T in, at the proposal of using it in the majority of patients, we know the majority of patients do relapse early if they're going to relapse. So that they would fit the eligibility criteria for ZUMA-7 in many cases. And the immediate sort of panic is the feasibility of applying CAR T in routine practice. And I realize that's going to vary by region. But putting that aside, the ZUMA-7 data are very compelling. The endpoints are fairly clear cut. The statistics are very good, and there does appear there is clearly a favorable outcome both for EFS and PFS in the experimental arm. One of the problems with these trials when you put them all together is that, of course, we haven't yet seen the nitty-gritty with the Liso-cel trial, but it is that for most centers, when these patients present with their relapsed disease, you have to start treatment straight away. And ZUMA-7 doesn't really explore that scenario exactly. So that raises the possibility that those patients weren't evaluated thoroughly by that trial, I suppose, in the minds of some people. And so it'll be interesting to see if a patient who started on salvage can access CAR T or not. And I don't know, how that's being approached, whether the approvals already exist.
Yeah, I'm happy to chip in. Of course, this is a subset of patients with diffuse large B-cell lymphoma. These patients are all within 12 months of completion of therapy. So, of course, we see late relapses in DLBCL. So the question about is it all over for the ASCT, and the answer to that is no. I do think, as Michael says, it brings on some really interesting questions. Those patients who were in ZUMA-7 didn't have concerns about organ compromise. They didn't receive any bridging therapy, and so for the dynamic of that disease is interesting, and perhaps not always reflective of many patients with primary refractory disease that we do see. So I guess it's going to be interesting to know what we're going to do with patients who do need to have some bridging therapy, particularly for us in Europe, where the timelines at the moment for CAR T cells are behind that of North America. And what do we do with those patients who have an excellent response to bridging therapy? Do we still go on to give the CAR, or do we think that there may still be a role for this stem cell transplant in that group of patients? So I think there's some really interesting questions to be answered. So clearly the data from ZUMA-7 is very compelling, and although we don't see an overall survival advantage yet, there looks like those curves are going to separate, and obviously there's the impact of the third line therapies that patients had subsequently. But I think the data is really very exciting, but there's still a role for ASCT and DLBCL.
I would answer yes, it is over. Because even for late relapse, we will have the choice of bispecific soon in second line, I guess, or bispecific plus chemotherapy, and then we'll not have the need to high dose therapy plus autologous stem cell transplantation. And then for the patients that are really refractory, relapsing very early after R-CHOP or first line therapy, we would like, I think, in the near future to use immunotherapy and not high dose chemotherapy. So for me, yes, I answer yes for sure.
Catherine, I'm going to feel constrained by what we can and can't do, and so I still think there's going to be a role, because I know that my funders are going to say, patients up until 12 months at that 12-month cutoff, then you're going to have to go back to the conventional way. So I still think that we'll be doing this for a little while, and I think there's quite a lot for the bispecifics to prove in this setting yet in terms of durability of response.
We'll see that.
Actually, I would agree with Catherine, but we may need another randomized trial between the bispecifics and the CARs. There's another question, and that's the extrapolation of the ASCT data to the non-transplant eligible patients. I mean, we hear rumors that may be in the label of some of the products without having had a trial in second line. So do you have an opinion on that?
I mean, there's in ZUMA-7, the subgroup there was a subgroup analysis for the older patients within the main paper. You could see the multiple subgroup analysis, and there was no suggestion that subgroup did worse, at least in what's been presented so far. So that's pretty convincing. But of course, we know that the patients who went into ZUMA-7 were perceived as being transplant eligible. Only a small proportion of patients fell off or came off voluntarily very early, having been randomized to the standard of care arm. So there's maybe some people who went on hoping to be randomized to the experimental arm, and then came off because they didn't want to go through the transplant. But there's still a relatively older population in ZUMA-7. So it suggests that if CAR T is tolerable, you're going to get good outcomes. And I don't know any treatment that reaches that bar that was achieved by the experimental arm in ZUMA-7. So I don't know. I can understand the reason why the label is being considered to be extended beyond that population, although I don't know how these decisions are made.
I think there are some data with liso-cel in second-line patients. So I think this was part of the phase 2 studies where there was a population of patients in second line. I think there are also ongoing trials in this population, so for non-transplant eligible patients going forward. So I think it's here. I agree a little bit with the word of caution regarding the durability of response with other things. I mean, ASCT is curative in a number of patients in late relapse. So before we throw it away, we have to be a little bit more sustained result of the bispecific. And Mike, I know you will present additional result at ASCO, but I haven't seen them. And I doubt we'll be with 5 years result because this is not the case yet. I would like also to jump with some categories of large cell lymphomas that were not necessarily well explored. We had a discussion in our group recently with a patient with primary mediastinal. These patients were not in ZUMA-7, and we do know that they respond to salvage and to transplant. There is also some other entity, T-cell, histiocyte rich or others. So I think we tend to generalize, but I think we have maybe a word of caution here for some of these entities that were either not represented, underrepresented. And well, I believe that most of the patients will go to CAR-T, and I will rather advocate for CAR-T. Alison knows that, but I think it's true that the data, if we look even in Transform, there were like, I think 7 or 9 patients with primary mediastinal, so that's not a lot. And I think we have to be a little bit careful when we move fast from treatments that are established in 30 years.
But Gilles, I would say to that we know that patients with primary mediastinal B-cell lymphoma probably respond less well to reinduction therapies, and we've seen that from some historical data. And we've seen in the third-line setting small numbers of patients with primary mediastinal lymphoma who have done very well with CAR-T. So I think it's not unreasonable to extrapolate that. I understand your caution, but I think it's not unreasonable to extrapolate that into the second line.
Personally, I agree, but I think we miss data. Let's put it like that. And I think the data regarding salvaging this setting may be different. Any other opinion to keep us on time about this topic?
I think it would be nice to see some real-world evidence of the results of CAR-T in second line, to see if the institutions have a learning curve, or if we can all reproduce these results.
Well, wasn't there that recent publication, in terms of real world evidence, with all its flaws, the retrospective review from CIBMTR recently in Blood, where the overall survival advantage was with auto, but of course it's, a real hodgepodge of patients. So I'm not quite ready to throw auto out the window yet for the long late relapses, particularly in those who can tolerate it. But, this early CAR T-cell is a pipe dream for us, isn't it, Michael?
I think it's a while away in our region from a practical sense, but we can work towards it and hope.
I guess the other thing we need to just remember is about the aftercare from CAR-Ts and the burden that also, has in terms of patients with ongoing cytopenias that may last some time, the ongoing B-cell aplasia with the immunoglobulins and the antibiotics and all the rest of it. So I do think we just need to remember it's not a simple one-off hospital stay and then you recover. There's a lot of things to think about with the ongoing care of these patients. So I think we need to always take that into consideration when we're thinking about the logistics operationally and the economics of CAR-T.
And the other thing I'd say is I don't think we're ready to lay down our guns. Or, CAR-T looks better in this randomized trial, but there's still a very large proportion of patients who weren't cured, and we want to do better, right? In this population, and it's still overall a bit disappointing that we didn't see higher CR rates overall, and the thing that I'm mulling over in my mind is what to do about that, and is our new control arm axi-cell or maybe lyso-cell for everything, and how's that going to work? How are we going to improve upon these outcomes, because they need to be improved upon.
And it needs to be substantially cheaper. We can't spend this sort of money on something that only 30% of people are alive 2 years later. That's a lot of rituximab and obinutuzumab I could buy for patients.
But I agree with what Michael said. There is this gap in efficacy which we need to improve on, and for me, it was particularly, I don't know, disappointing, but actually surprising that the response rate in the second line was not higher than what we had seen in the third line. Right, the bar has not moved much up, despite moving to the second line.
But Greg, the population was a bit different. I mean, let's not forget that.
I agree.
Yeah.
Greg, do you think that there is options also for or other immunologically based approach in patients that are not transplant eligible? You presented some data regarding the comparison of Tafalen versus CAR-T in a handful of patients. There were not apparent differences in these results?
That's correct. Those patients were matched to L-MIND study, as you're aware. So that's a little bit different population, but in those closely matched patients to L-MIND-like population, there was no difference in a small cohort of patients. So that's more of an exploratory hypothesis generating study. But those approaches look very interesting. I think if you add to it the possibility of bispecifics added to either IMiDs or even IMiDs with tafasitamab or other combinations, I think there's a huge potential that those combinations could actually move forward quite rapidly. I think the durability of responses with bispecific keeps getting better, and we'll hopefully see it soon as well. And the nice thing about bispecifics, in contrast to CAR T cells, they can be actually combined fairly easily with different backbones. And one of those would be a tafasitamab and lenalidomide, but you can imagine many other immunological backbones that bispecifics could be added to.